Good morning, everyone, and thank you for being here today. I am excited to share with you our study on socio-demographic characteristics of our patient population. Today, we'll be exploring some key data points, starting with the gender distribution. Note that 63.2% of our respondents were male patients. We'll also look at age, where the median age was 36 years, ranging from 15 to 92 years. Additionally, it's interesting to see that about 8% of our patients, specifically 29 individuals, were aged 70 or older. Finally, a significant portion, around 7% of our subjects come from the nearby district called Shebedino. Throughout this presentation, we'll discuss what these characteristics might mean for our study and the community we serve. So, let's dive into the details and see what the data reveals. On arrival at the emergency department, we observed that nearly 2/3 of the patients, specifically 62.4%, were non-trauma patients. This indicates that a significant portion of cases were medical rather than injury-related. When looking at vital signs, about 29.1% of these patients were tachycardic, meaning their heart rates were elevated, which often signals stress or underlying illness. Additionally, a large majority, 83.5%, were tachypnic, indicating rapid breathing, which can be a response to respiratory distress or other systemic issues. Fever or cold extremities were noted in 31.3% of the patients, showing that some had signs of infection or circulatory compromise. More than a third, specifically 36.8%, had low systolic blood pressure, which can suggest shock or hemodynamic instability. Furthermore, about 2/3, or 65.4%, had low oxygen saturation levels, highlighting the prevalence of hypoxia among these patients. Interestingly, only 8.5% of the study subjects reported no pain at all, emphasizing that pain remains a common presenting symptom. Overall, these findings underscore the diverse and often unstable clinical presentations of patients arriving at the emergency department, which reinforces the importance of rapid assessment and tailored management. Let's take a closer look at Table 1, which outlines the vital signs and conditions of patients who visited the emergency department at Leku Hospital. Starting with pulse rate, we see that about 70.9% of patients had a normal pulse, while approximately 29.1% were experiencing tachycardia, which indicates a faster than normal heart rate. Moving on to respiratory rate, an overwhelming 83.5% of patients had tachypnea, meaning rapid breathing, with only 16.5% maintaining a normal respiratory rate. This suggests that breathing difficulties are quite common among these patients. Regarding body temperature, 31.3% exhibited hyperthermia or hypothermia, indicating abnormal body temperatures, while the majority, 68.7%, had normal temperatures. When we look at systolic blood pressure, a significant portion, 36.8%, were hypotensive, meaning they had low blood pressure, whereas 61.5% maintained normal blood pressure levels and a small percentage, 1.7%, were hypertensive. Peripheral oxygen saturation shows that 65.4% of patients were experiencing hypoxia, which is low oxygen levels in the blood, with only 34.6% having normal oxygen saturation. Lastly, considering pain, the majority of patients, 91.5%, reported experiencing pain, while only 8.5% reported no pain. What these figures tell us is that abnormal vital signs, such as rapid breathing, low oxygen saturation, and low blood pressure, are quite prevalent in this patient population. This highlights the importance of vigilant assessment and prompt management in emergency settings. Overall, this table underscores the critical need to monitor vital signs closely, as they provide essential clues about the patient's condition and help guide immediate care decisions. So, in this slide, we're looking at the distribution of triage categories assigned by the first nurse at the emergency department of Leku Hospital. As you can see, the largest portion, about 37.4%, falls into one particular category. This indicates that a significant number of patients are being classified in this group, which could reflect the severity or urgency of their conditions. Following that, 31.6% of patients are in the next tier, showing that a substantial portion of cases are moderate in urgency. Meanwhile, 25.5% of patients are assigned to a different category, perhaps indicating less critical cases. And finally, a smaller percentage, around 5.5%, falls into the least urgent group. These figures are important because they help us understand how patients are being prioritized upon arrival, which directly impacts the flow and efficiency of emergency care. By analyzing these triage distributions, we can identify areas where we might improve patient management or adjust our triage protocols to ensure timely care for those who need it most. This slide really highlights the importance of accurate triage in delivering effective emergency services. In this slide, we're looking at the agreement between two nurses when they categorize patients in the emergency department at Leku Hospital. The table shows how often they agreed or disagreed across different triage categories. The key takeaway here is the kappa value, which is 0.709. This indicates a substantial level of agreement between the nurses, meaning they generally see eye to eye when assigning triage categories. The p-value is 0, which confirms that this agreement is statistically significant, so it's unlikely to have occurred by chance. Looking at the table, you can see that most cases fell into categories 1 and 2, with a high number of cases where both nurses assign the same category. Those are marked with an asterisk. For example, in Category 2, there were 63 cases where both nurses agreed, which is quite substantial. This high level of agreement is important because it supports the reliability of our triage process. When nurses consistently categorize patients similarly, it ensures that patients receive appropriate care promptly, which is the ultimate goal of triage in emergency settings. So overall, this slide highlights that our nurses are reliably assessing patients, with agreement levels that are considered substantial, reinforcing the consistency and trustworthiness of our triage system here at Leku Hospital. In this part of the study, we're looking at the reliability of triage, which is essentially how consistently patients are categorized based on their urgency. Our findings show that the triage reliability in our current study aligns quite closely with previous research, such as the study by Wuas and colleagues from 2000, which reported about 77% reliability. This suggests that our results are fairly consistent with established data. Interestingly, when we compare this to other studies from different regions, like the one conducted in Iran, which showed a slightly lower reliability of 72%, it indicates some regional or contextual differences. On the other hand, studies from Pakistan and Switzerland report higher reliability rates, 87% and 89% respectively, which raises questions about what factors might influence these variations. These differences could be due to a number of reasons, including variations in the study setting, the specific triage tools used, or the characteristics of the study subjects. It's important to recognize that these factors can significantly impact the consistency of triage decisions. Understanding these nuances helps us appreciate the complexity of triage reliability and underscores the importance of standardization and context-specific training to improve it across different settings. This is a key part of ensuring effective emergency care, which ties back to our overall goal of improving triage accuracy and patient outcomes. Now, let's take a closer look at the table illustrating the physician's triage categories alongside the kappa values and p-values. These figures help us understand the level of agreement between different triage assessments. For example, the first nurse triage category shows a kappa of 0.131 with a p-value of 0, indicating a fair level of agreement that is statistically significant. Notice the asterisks next to some numbers. These highlight where there's notable agreement or discrepancy. For instance, in the second triage category, we see a kappa value of 0.45, which suggests moderate agreement, also statistically significant. Moving to the overall accuracy, we see that 131 or 36% of triages were correctly identified by the first nurse. While that might seem modest, it underscores the importance of improving triage accuracy to ensure patients are appropriately categorized from the start. This table really emphasizes the challenges and successes in triage accuracy at Leku Hospital's emergency department, which ties back to our broader discussion on optimizing patient flow and care quality. In this part of the study, we found that about 64% of triages were inaccurate, which is quite significant. When we compare this to other studies from different regions, the differences become even more interesting. For instance, in Turkey, the inaccuracy rate was around 40.7%. In southern Thailand, it was 47.6%. In South Africa, it was lower at 28.3%. And in South Korea, it was only 14.7%. These variations could be due to several factors. Differences in the study settings, the triage tools used, and the standards for evaluating accuracy all play a role. Additionally, the characteristics of the study subjects and the sample sizes might also influence these results. Understanding these discrepancies helps us see how context and methodology can impact triage accuracy, which is crucial as we work towards improving emergency care across different regions. Now, moving on to slide 9, let's talk about the analysis methods we used. First, we performed a bivariate analysis, which helps us identify potential associations between individual patient factors and triage inaccuracy. In this step, we considered factors with a p-value less than 0.25 as potentially relevant. This threshold allows us to cast a wider net initially, so we don't miss any important variables. Then, we advance to multivariable analysis, which refines our understanding by examining multiple factors simultaneously. Here, we considered factors with a p-value less than 0.05 as statistically significant, indicating stronger evidence of association. The factors we analyzed include age, pain, trauma, pulse rate, body temperature, level of consciousness, chief complaints, and mobility status. These are all key patient characteristics that could influence triage accuracy. As we discuss these results, keep in mind how each factor might impact triage decisions and overall patient outcomes. This part of the analysis helps us pinpoint which patient factors are most strongly associated with triage inaccuracies, guiding us toward targeted improvements in our process. We'll continue to explore these findings as we move forward in the presentation. Now, let's look at how patient factors can influence triage accuracy, starting with age. Patients aged 70 years or older were found to be 5.5 times more likely to be triaged inaccurately compared to younger patients under 70. This is reflected in an adjusted odds ratio of about 5.49, with a confidence interval ranging from 1.188 to 25.408, and a p-value of 0.029, which indicates statistical significance. This finding isn't isolated. It's actually consistent with previous research conducted in Brazil, such as the study by Hinson and colleagues in 2018, and also with research assessing how well disease severity scores perform for older patients with sepsis in the emergency department, like the study by de Groot and colleagues in 2017. The reason behind this increased likelihood of triage inaccuracy in older patients could be that they often present with nonspecific signs and symptoms. Additionally, many of these patients have multiple comorbidities, which can make assessment and triage more challenging. So overall, this highlights a critical point. As patients get older, their presentation can be more complex, and this complexity can lead to difficulties in accurately triaging them, which is an important consideration for improving emergency care quality. Let's take a closer look at how pulse rate can influence triage accuracy. Patients who experience moderate tachycardia, meaning a significantly elevated heart rate, are actually 3 times more likely to be triaged inaccurately. This is supported by an adjusted odds ratio of 3.033, with a confidence interval ranging from 1.012 to 9.093, and a p-value of 0.048, which indicates statistical significance. This could be because factors like traveling on foot or being under stress can elevate the pulse rate temporarily, making it harder to interpret correctly during triage. Essentially, our findings suggest that abnormal vital signs, like an increased pulse, may sometimes lead to misclassification, especially when the cause isn't directly related to the severity of the condition. Understanding these patient factors helps us identify potential pitfalls in triage accuracy and highlights the importance of considering the broader context, like patient activity or stress levels, when assessing vital signs. This ties back to our overall goal of improving triage processes to ensure we don't overlook or misjudge patients who need urgent care. Now, let's look at how pain as a factor influences triage accuracy. Patients experiencing moderate pain are actually 7.4 times more likely to be triaged inaccurately. This is supported by a study showing that predicting urgency is more accurate for patients who are not in pain. Essentially, pain complicates the triage process because it can be influenced by other factors. For example, anxiety can worsen a patient's perception of their pain, making it seem more severe than it actually is. Plus, some patients may exaggerate their pain to get more urgent care. These factors highlight why pain assessment can sometimes lead to misclassification, and why understanding these nuances is crucial for improving triage accuracy across the board. Let's look at some additional patient factors that influence triage accuracy. Specifically, trauma versus non-trauma patients. Interestingly, non-trauma patients were found to be 37 times more likely to be triaged inaccurately. That's quite a significant difference, with an adjusted odds ratio of 37.191 and a confidence interval from 3.108 to 445.007. This finding aligns with a previous study that used case scenarios, conducted by Jordy and colleagues in 2015, which also pointed to similar issues. One possible reason for this discrepancy could be that the triage tools currently in use tend to give less attention or weight to non-trauma patients. As a result, their conditions might not be assessed as accurately, leading to higher rates of triage errors. So overall, this highlights an important challenge in our triage processes. It's not just about trauma cases. We need to ensure that non-trauma patients are also accurately assessed to improve overall patient outcomes. This ties back to our broader goal of refining triage tools and training to minimize these mismatches and improve reliability across all patient categories. So, to wrap up our findings, the overall triage reliability was at a substantial level, which is encouraging because it suggests that our triage system is generally dependable. However, it's important to note that the majority of patients were actually inaccurately triaged, indicating room for improvement. We also identified certain patient factors that are associated with these inaccuracies. Specifically, older age, particularly those aged 70 and above, moderate tachycardia, moderate pain, and cases that involved non-trauma situations tended to be more prone to triage errors. These insights are crucial because they highlight specific groups and conditions where our triage process might need refinement. So, in terms of conclusions and recommendations, I think the key takeaway is that while our triage system is fairly reliable, we need to pay special attention to these identified factors. Improving accuracy for these groups could lead to better patient outcomes and more efficient resource allocation. Addressing these issues should be a priority moving forward, ensuring that our triage process is as precise and equitable as possible across all patient populations. Let's wrap up with some key recommendations moving forward. First, it's crucial to regularly monitor and evaluate the triage process. By doing so, we can identify areas for improvement and ensure that our system remains effective and responsive. Next, updating the triage system itself is essential. Technology and protocols evolve, and our systems should reflect the latest best practices. Additionally, we should consider conducting further prospective observational studies. These studies will help us gather more real-world data, validate our approaches, and refine our strategies. In conclusion, these recommendations are all about continuous improvement and staying proactive. By implementing these steps, we can enhance patient outcomes and ensure our triage processes are both efficient and reliable. Thank you for your attention and commitment to this important work.